Thank you, Elizabeth. Thanks, Rami and Serge, for inviting me to give this talk. I will admit up front, I'm not really going to talk about ET and PV. It's mostly MF. I think that the PV part, Brady, already covered, and I would perhaps in the future do an ET-PV focus talk, but I'm going to talk a little bit about ET and then mostly about myelofibrosis and advanced forms of myelofibrosis. I have a lot of slides. I'm a pretty aggressive presenter. I'm going to try to do this by keeping you guys entertained. You'll let me know if that works. So this is the slide I'm starting out with, which is evaluating Ruxolitinib in ET and PV. And these are some of the studies right now that are ongoing or have been completed, just a selection of studies. And I'm just going to, again, move beyond PV. PV with Ruxolitinib, I really think, is a indication right now for high-risk PV patients who are intolerant or resistant to hydroxyurea, and you put them on Ruxolitinib. It's clearly been shown by the response trials to be a superior agent. I'm going to move beyond that. And let's talk about ET a little bit and then myelofibrosis. So this is a study I chose to talk about. I don't know how many people in the audience are really familiar with this. The MAGIC trial, M-A-J-I-C. This was a phase 2 study, a randomized study, about 110 patients that Claire Harrison has presented previously with high-risk ET by one of the risk factors that we'd already discussed, and they were randomized to either Ruxolitinib or best available therapy. Now, these patients already had hydroxyurea and were deemed intolerant or resistant by ELN criteria. What they saw in this trial was there really wasn't a difference between the two arms in terms of outcomes. I think it was like 47% versus 42% in terms of responses at 1 year. But there was numerically, and not statistically significantly, but numerically a higher number of thrombotic events, progression to MF and AML, and infectious complications in the Rux arm compared to the best available therapy arm. However, the symptom improvement was, as one would expect, better with Ruxolitinib than best available therapy, and that's where I would focus my attention on when looking at an ET patient that you might want to prescribe a JAK2 inhibitor for off-label. So I just put these two slides up just to make a point. There were 5 CRs in this study. All were with the Rux-treated patients, and you can see them there. That included JAK2 mutated and CALR mutated patients. There were no molecular responses in the patients that got best available therapy. And then if you look down at a correlation that they try to do with molecular responses and symptom improvement, really the symptom improvement was only correlated with molecular response as it relates to fatigue, early satiety, and abdominal discomfort. So in ET, the data is still unclear. The jury's out. How best to evaluate Ruxolitinib in this setting, I think, is a challenge for those that are doing this professionally, and then where this would fit into the treatment algorithm. I personally think that Ruxolitinib is a reasonable drug if you have a high-risk ET patient, particularly a symptomatic patient who doesn't respond the way you're intending with hydroxyurea. So, as I promised, one last slide, RESET study. I just recently learned about the RESET study. So this is a double-blind, double-dummy phase 2 study. It's 120 patients, just started in April, and it's randomizing patients who are high-risk ET again, who are resistant or intolerant to hydroxyurea, to either Ruxolitinib or Negrelide. And Negrelide seems to be making somewhat of a comeback these days. And the primary endpoint is normalization of the white count and platelet count at a year of therapy. So this is yet to be determined and is ongoing. Okay, so MF and Ruxolitinib. I mean, most people here, probably everyone here is aware of the indication of Ruxolitinib for myelofibrosis, which is intermediate and high-risk patients. I will say that there is a low-risk patient population that's symptomatic that I think is deserving of Ruxolitinib because patients can have spleen-related symptoms or other odd symptoms that may not classically meet the constitutional symptoms that would put them into the intermediate 1 category. So if you have a low-risk patient who has symptoms, that's a reasonable patient, I think, to use Ruxolitinib. And there's a trial that we'll talk about called the RETHINK trial that's going to be evaluating this formally. Then you always have to figure out very quickly, I think, when you see a patient, are these patients transplantable? Because that's really the first thing I always consider when I meet a patient based on their age, their performance status, and other variables. Because although Ruxolitinib is a fantastic drug, transplant is definitive, and you don't want to not think about that or not approach that with the patient. And then the dilemma of someone who comes in very anemic, who is dead set against getting anemia with Ruxolitinib or inducing anemia, that's also a discussion and a consideration. So what do we know about Ruxolitinib now in 2017? I'd like to start with this slide. This is the 3-year update from the COMFORT studies presented previously and published. And at the median follow-up of 3 years at this point when published, 50% of the patients had come off study, about 25% for progression of disease, 20% for adverse event, another 20% for death, and about 15% for patient decision. And in my mind, in clinical trial talk, patient decision usually means that they're losing response. They're not feeling as well as they may have, and that is often a reason for stopping. So when your patients say, well, how long am I going to stay on this ruxolitinib? I say, well, the median is about 3 years, and some patients can stay on it 8 or 9 years. I know Serge has probably one of the longest standing patients to date. But the fact of the matter is that patients don't always stay on this drug. They may get an initial benefit and sometimes lose that benefit, and one must be aware of that. What we do know from this data is that you don't get late-term myelosuppression, which can be a problem. So you do drop the platelet count, well established. The DLT for this drug is thrombocytopenia, but you don't get late-term or late-stage myelosuppression. The hemoglobin actually sits pretty comfortably a gram per deciliter below the starting hemoglobin. So you get this predictable drop 8 to 12 weeks, and most patients will ride it through. You maybe transfuse them through it, and they will settle down. You don't see year 3 anemia. What about spleen volume reduction? We know it's a fantastic drug for reducing spleen. That was the primary endpoint, and 80% or 60% of patients achieved that within this time period. 80% of patients that achieved it maintained at least a 10% reduction in spleen volume during this period, and 10% has been shown to be clinically relevant and important. What about survival? So this was an analysis that Serge did and has published already, looking at the phase 1/2 patients, I think 100 and something patients from his institution. And I like this slide because it brings out a point that I often think about when we're treating these patients and looking at their spleen response. The point is that if you looked at spleen reduction as it correlates to overall survival outcome, patients who had I don't know if this pointer works, maybe not. Patients who have a 50% or greater reduction in spleen volume had a better outcome than patients who had less than 25%. It sort of begs the question, how should you dose these patients? Should you dose them to spleen response or dose them to symptom improvement? Should you look at the counts as the mediating effect? So it's just food for thought, because this would suggest that spleen volume reduction is an important biological endpoint. And what about overall survival? So in an intention to treat analysis, which these two curves show here, there was still a statistically significant difference in outcome now at 5 years in the COMFORT-1 study. This has also been shown in the COMFORT-2 study by Claire Harrison and colleagues. And in this analysis, they compared the 3 curves. The first curve is Ruxolitinib, which wasn't met at this time point, 5 years. And then the second curve, which is in blue, is intention to treat, 4.2 years. So regardless of the patients crossing over from best available therapy to Ruxolitinib, they remained in that category. And then the third curve is a statistical tool that I learned about maybe a year or two ago called the RPSF2, Rank Preserving Structural Failure Time. And what it basically does is it predicts what would happen to these patients if they had never crossed over from best available therapy. They'd stayed on whatever drug they were on, and then follow them out that way. And in the median survival in this projected group would have been 2.7, median overall survival 2.7 years. So this would suggest that there really is a overall survival benefit to Ruxolitinib. I think it's probably mainly mediated by symptom improvement and performance status rather than clonal response. Anemia, this is an important, so anemia always comes up, and do you do a disservice to a patient if you start them on Ruxolitinib and induce anemia? And this slide, I think, speaks nicely to the fact that no, you don't. So therapy-related anemia has a different impact, or maybe no impact necessarily on outcome as disease-related anemia. So patients who developed anemia from the disease when compared to a corresponding degree of anemia on Ruxolitinib didn't fare the same. This was a different impact on survival as shown on these curves here. What about mutations? And this was brought up briefly previously. This is analysis, again, done by the MD Anderson group looking at patients from the phase 1/2 study. And what the point is made here is that if you have 3 or more mutations, so JAK2, for example, ASXL1, and TET2, you're more likely to not garner the full benefit in terms of survival, at least, than patients who have less than 3 mutations. So that the mutational complexity, the complexity of the disease, also probably predicts a response. It may also suggest that the earlier you start the drug, before it becomes too complex, the more likely that you'll garner the optimal effect of the drug. The problem with Ruxolitinib, not the problem, but what you need to be aware of with Ruxolitinib is that patients can feel well, they can have a reduced spleen, but they can still have progression of disease. And this was a series that we presented from our institution. About 4 or 5 patients out of 40 at the time that we looked at on Ruxolitinib with myelofibrosis that developed leukemic transformation. In this case, it was odd, leukemia cutis, which I have to say I don't normally see when patients progress or evolve into AML. So if you get a patient who's on Rux who's doing fabulously well and has a new rash on their back, just be aware that this entity can occur. The RETHINK trial. So the RETHINK trial, I think, is an attempt, a valid and important attempt to use ruxolitinib earlier on in the disease course. So this is low-risk patients that are symptomatic, have a spleen, and have at least one of these high molecular risk genotypes, whether it's ASXL1, EZH2, SRSF2, IDH1 or 2. And if you have one of these, you're considered a high-risk patient, and you'd be eligible for this randomized study of Rux versus placebo. So this is an ongoing study, which will be interesting to see if patients who are earlier in the disease course should be treated with ruxolitinib. So we can't have an entire talk about JAK inhibitors with just ruxolitinib in 2017. We'll talk a little bit about the persist program. This is the pacritinib JAK2 FLT3 inhibitor. This was the persist-1. This was a study presented by Ruben Mesa at ASCO, or no, ASH, no, maybe it was ASCO 2015, I'm losing track of time, and now published at Lancet Hematology. So this is the persist-1 study. This took patients with intermediate or high-risk myelofibrosis and palpable splenomegaly, irrespective of their platelet count, and treated them with, and these patients were JAK2 naive, and treated them in a 2-to-1 fashion with pacritinib 400 milligrams once daily versus best available therapy that also excluded ruxolitinib. The primary endpoint here is sort of the classic 24-week spleen volume reduction. And what you saw is that there was, and this is a subset analysis, but what you saw was a positive study. It clearly was an effective drug in reducing spleen. But most importantly, in my mind, this was in an unmet need, which is less than 50,000. So in patients who had very low platelets, which is advanced disease, very sick patients, who would be by label not eligible for ruxolitinib, there was 23% of the patients met that primary endpoint versus 0% in an intention to treat analysis. And importantly, in patients who were transfusion dependent at baseline, and about 25% of those patients met criteria by Gale for transfusion independence with this drug, pacritinib. Very different than ruxolitinib in that respect. And you really do see less myelosuppression with pacritinib. So these are the adverse events. As one would expect with a FLT3 inhibitor, there's probably a little bit more diarrhea, nausea, and vomiting. It's usually low grade. It's not really a reason for discontinuation. And this is investigator-reported anemia and thrombocytopenia that's shown here, which is also not frequently high grade or a reason for discontinuation. The PERSIST-2 was a study that complemented this PERSIST-1 study that was presented as a late-breaking abstract at ASH last year. This was a randomized phase 2 trial. Now, this was different. It was low platelet patients, and these patients could have seen a prior JAK2 inhibitor, and they were randomized 1:1:1 to PAC 400 a day, 200 twice a day, or best available therapy, and this could include ruxolitinib. So this is, in my opinion, a fantastic study because it really took a heavily treated, yeah, I know I'm biased, heavily treated patient population and treated them against the best available therapy, which in this case, 40% of the patients was ruxolitinib. This is a co-primary endpoint at 24 weeks was spleen reduction and symptom improvement. So co-primary endpoint, I have to point out, this was a pooled analysis, so looking at the two doses, 400 and 200 twice a day, compared to best available therapy. So the problem was, let me show you, and then I'll tell you what the problem was. So the drug really was effective. If you look just at the BID dosing, 200 BID, it was effective in both spleen volume reduction and symptom improvement at 24 weeks compared to best available therapy. Highly effective. The problem was the trial was designed to look at the two cohorts combined, and although it made its co-primary endpoint of spleen volume reduction with a statistically valid p-value in the combined cohort at 18% versus 2.8%, for symptom improvement, it was shy of what was needed, and it was 24.8% versus 13.9%. But the 200 BID was really where the money was. Now, if you look at spleen volume reduction or total symptom score, I like these waterfall plots, and they show you the QD, BID, and then the best available therapy with ruxolitinib in red. You do see that there are a spectrum of responses. So, sometimes we concentrate so much on this 50% symptom improvement, 35% spleen volume, that we forget that there are other patients who respond, maybe not as much, who still garner benefit from these drugs. And I think these waterfall plots speak nicely to that effect. You didn't get thrombocytopenia with this drug. In fact, maybe a slight improvement, even in patients with low platelets. And everyone's aware of this drug was unfortunately put on a clinical hold, full clinical hold in March of 2016, based on preliminary data that the I was going to say FBI, but the FDA was looking at that concerned them about early deaths, perhaps related to cardiovascular or bleeding events. I think that this survival curve really speaks to the fact that there really isn't a difference between these three curves. If anything, I'd rather be on the green curve, which is the 200 BID curve. And then just to make the point even more, just focus in on, if you look at the deaths due to AE, the events of interest, at least from the FDA standpoint, were cardiac adverse events and bleeding events. They're very small numbers, and there's clearly not a difference between best available therapy and the pacritinib arm. So luckily, this drug was taken off clinical hold in January, and there's clinical development moving forward. This is the PAC-203 study. This is a study, I think an important study, and sort of will give patients a new JAK2 inhibitor to try in the clinic. In patients who have advanced myelofibrosis, low platelets, and had to have failed ruxolitinib previously. And it's randomizing them to the 200 twice a day, which I still think is the ideal dose, but the FDA wanted to see some PK, PD, and some toxicity data coming out of lower doses, which is what we will also do. And the primary endpoint will be spleen volume reduction at 12 and 24 weeks. So this study is now ongoing. I think it's enrolled 3 or 4 patients at this point, and is going to aggressively move forward. Now, people in the field know that, unfortunately, the simplified studies weren't positive studies. I won't spend a lot of time on this, but just sort of point out, for those of you who are interested, momelotinib is a JAK1/2 inhibitor, much like ruxolitinib, but perhaps not exactly. And in the simplified 1 study, so maybe this drug is different because it has some activity against activin type 1 receptor, and that modulates hepcidin expression. Perhaps that might explain, in part, the improvement in anemia that was seen in the early phase studies that sort of distinguished itself from ruxolitinib. So in the simplified 1 study, this was JAK-naive patients, large study, 422 patients, randomized to MOM 200 once a day or Rux 20 BID. Primary endpoint is spleen volume reduction at 24 weeks. And what you see is it met its primary endpoint. And in this study, it had to be non-inferior. So meeting the primary endpoint meant non-inferior to ruxolitinib, in which you can see from these 2 waterfall plots and the spleen volume reduction percentages below, it met its primary endpoint. Unfortunately, for the secondary endpoint of symptom response, it didn't meet it, and it was inferior to ruxolitinib. However, I think what is interesting about this drug is you don't get the kind of myelosuppression. In fact, you get an improvement in hemoglobin that seems to be durable and maintained throughout this study, as well as stability in the platelet count. There is peripheral neuropathy. This has been written about by some investigators, and it is noted previously. This may be a class effect to some extent, although I'm really unaware of any real neuropathy issues with ruxolitinib. But here you get some peripheral neuropathy. Some may be reversible, some may not, but usually low grade. The Simplified 2 is a study that's also been presented. Both of these were presented at ASCO. This was taking this was a heavily pretreated patient population, randomizing momelotinib or best available therapy. And basically the punchline is, unfortunately, the primary endpoint of spleen volume reduction was not met here, sadly not met. And the symptom response here was. So it was sort of the reverse of the Simplified 1. So one last JAK inhibitor that I'll mention, which is the NS018. This is a highly selective inhibitor that inhibits the mutant form of JAK. Serge was kind enough to lend me these slides. This is a phase 1/2 study. So this is early on. This is not mature like the momelotinib and the pacritinib studies. But in this study, with a median of 9 cycles, we get a sense of sort of the hematologic toxicity that's seen with a very selective JAK2 inhibitor, as shown on the right. And the fact that, again, we are seeing some neurologic adverse events, whether it's peripheral or central nervous system, in about 17% of patients. So early on, but there's some activity with this drug, as one can see by spleen volume reduction here. And you get a spectrum of responses. And this is color-coded by whether patients were refractory or resistant or intolerant to previous ruxolitinib therapy. And same with symptom improvement. So this is a drug that still has a ways to go, but maybe a player on the block that still needs to be developed further. I felt compelled to talk about this very quickly, which is a selective JAK1 inhibitor. I know Insight's in the audience, I still think this is a great drug. This drug should be developed, I think, for patients with low platelets. This was a study that we did, a phase 2 study, that showed that a selective JAK1 inhibitor that spares JAK2, so you shouldn't get the kind of myelosuppression, really resulted in a very nice improvement in symptom response, particularly, I think, with the 200 BID group. Perhaps not as impressive with the spleen reduction, which one would surmise because you're not blocking JAK2 signaling. You don't get the kind of myelosuppression you would get with ruxolitinib. and patients maintain their hemoglobin very nicely, particularly the patients that you can look at very cleanly that weren't transfusion requiring at baseline. So this is a slide that summarized my feeling about Rux combination side. I don't really know what to do with this. It's a topic we've talked about before and that I've been engaged with over a number of years. And the question always is, when you embark on a combination study, what are you trying to do or achieve? Is it simply greater spleen reduction? Is it greater symptom improvement? Is it improvement in disease-related cytopenias, which would be sufficient? Or are you looking for deeper molecular responses? Does that actually mean something clinically important for the patient? Or should we be looking just at bone marrow morphologic responses? And then how useful and how adequate do the combined response criteria that we use really capture what we're trying to achieve in patients when we add another agent to ruxolitinib? This is a busy slide, but it's really more to make a point that there are a number of they're essentially all Rux-based combinations. And the partners are often mechanism-based, and they have preclinical rationale like PI3 kinase inhibitors shown here. I don't have enough time to go through all of these. These are all still early on. I would make the blanket statement that unfortunately we haven't seen a real winner yet in any particular combination. Perhaps just not enough time. This is a sort of an attempt to alleviate some of the therapy-related anemia, whether it's by adding an IMiD or adding danazol. We did a phase 2 study with Ruben where danazol didn't really seem to really add much in terms of anemia response with patients going on to ruxolitinib. And then epigenetic therapies. I've spent a good portion of my own particular research career looking at panabinostat, either alone or in combination with ruxolitinib. Last year I probably would have shown you those slides. I've stopped doing that now. I still think that Pano is an active agent. We never really figured out how best to deliver it, and I still think it has activity with ruxolitinib. And for those of you who are interested, I'll review the data offline. Then there's a whole hodgepodge of different drugs, including Pegasus and other medications, as well as sort of the role of Rux in transplant, whether immediately before allotransplant and now used for GVHD prophylaxis and trials, or an autotransplant approach, which we attempted at our institution but couldn't enroll anyone. So the 114 study, I'll briefly talk about. This was an MPD Arcy consortium study that was run by Vikas Gupta in multiple centers, looking at very intensive Rux treatment to reduce spleen for 60 days prior to conditioning with fludarabine and busulfan. So you immediately taper and then start the conditioning regimen to try to avoid any kind of rebound phenomena. And the primary endpoint was proportion of patients that were alive and engrafted at day 100. And we looked at cytokines. This has been presented previously, and the final results will be published likely next year. So in the related arm, this was stratified, related and unrelated. Related arm, unfortunately, we had 3 failures up front, which was progression to AML, sudden death, and graft failure. And that, unfortunately, led to the closure of the related arm. I don't think that any of these 3 necessarily were related to Rux. It was sort of unfortunate. And in the unrelated arm, we had 4 failures that allowed, actually, for that arm to progress to the stage 2. Again, the final results of this study have yet to be presented or published. We've only presented the interim analysis at a very short period of 8 months follow-up, where 75% of the total group were alive. And you can see the curves on the right, which I think don't really tell us too much quite yet between related and unrelated. So more to come on Rux in that setting. I'll very, very briefly talk about Rux plus decitabine. I think Rajit's going to mention this tomorrow in his talk. This is a 109 study, which is a consortium study, taking MPN, AML, or blast phase disease and treating them with combination Rux and decitabine. This is based on preclinical rationale that comes from Ross Levine and Rajit Rampal in a JAK2 p53 knockout murine mouse that sort of embodies MPN-related AML. And you can see that in the curves here, with increasing doses of Rux or decitabine alone, you get dose-dependent reduction in clonogenic activity of these cells when placed in methylcellulose. And this is amplified or synergized when you have Rux and decitabine together. We've published single-agent activity, data on single-agent activity decitabine, as well as others, and Serge's group has done a couple of phase 2 studies of high-dose ruxolitinib with modest effect. So we're combining the two, and again, Rajit will tell you some more of the details likely, but the median overall survival of this phase 1 study is pooled, everyone together. It's sort of an unfair analysis. It's 10.4 months. The problem here is I'm not sure that's really that much better necessarily than decitabine alone, and that's sort of where the phase 2 is going to come out. And for the phase 2, that's already accrued, and we're following the patients 25 patients treated across the country. The starting dose for induction is 25 BID of Rux. This is decitabine, the classic 20 for 5 days, cycled every 4 weeks. And then after the first month, it's a maintenance of 10 milligrams twice daily. And I can tell you, patients can stay on that and benefit from that. And we'll see what the long-term follow-up shows. So this is something that occurred to me occurred to me in the past, but while I was making this talk, and I know I'm over. I'm going to finish this up soon, I promise. Is how do you define ruxolitinib failure? And this is a problem. A lot of the trials we do now have different definitions for ruxolitinib failure and what would allow those patients to come on study. So this was my attempt to start to actually define this phenomena of ruxolitinib failure. As you can see here, primary resistance, secondary resistance, intolerance, and progression. I'm not going to go through the whole thing. I'm just going to tell you that I like to think I'm the first one to really do it. I'm not really, though, because the Mayo Clinic group put something out a couple of years ago. But what I'd like to do is actually have any of the investigators in the audience have more of a consensus sort of agreement on what this was and publish this. So lastly, potential JAK inhibitor positioning in MF. Like I promised, I didn't really talk about ET or PV. I really concentrated on MF for this talk. So for first-line initial therapy with a JAK2 inhibitor, for those patients who are thrombocytopenic, I think, again, I'm biased. Pacritinib, I think, is really a very great drug for this patient population, and hopefully the clinical development will move forward and this drug will become commercially available for patients. I still think the JAK1 inhibitor, selective JAK1 inhibitor, is a drug that can improve symptoms in this setting in patients who have low platelets. And if you're transfusion dependent, again, pacritinib, itacitinib, the JAK1 inhibitor, it's unfortunate that momelotinib will likely not be part of this game anymore. And then for second line, if you have ruxolitinib resistance, I think ruxolitinib combination therapy trials really should be the focus for patients in the community. If they can get to a center that has a trial, or again, pacritinib, I think is hopefully going to be a drug that's positioned here, and the PAC-203 study should help us with that. And then if you're ruxolitinib intolerant, I think pacritinib, itacitinib, and again, poor momelotinib could be considered there too. So in summary, ruxolitinib remains the only approved JAK inhibitor. It's for PV and MF. It's not labeled for ET. Pacritinib and other JAK2 inhibitors can fill an urgent unmet need in thrombocytopenic MF patients in second line to Rux. There's consensus definition that's needed, I think, for ruxolitinib failure, particularly as we move forward in clinical trials. Incorporation of mutational profiling may guide clinical decision-making. As we saw, if you have a complex mutational profile with 3 or more lesions, then you may be less likely to enjoy the full benefits of ruxolitinib. That may be consideration for transplant sooner rather than later. Rux is highly effective in addressing spleen and symptom, no doubt about it, but it doesn't clearly change the clinical burden of either PV or MF, and that's really, as investigators, I think what we're interested in accomplishing. There's really, and I say this to many of the colleagues I have in the community, don't follow serial mutation burdens. Don't get MRIs of the spleen. Don't keep doing bone marrows every year. It doesn't really help. Outside of a clinical trial, there's really no need to do this. It adds expense and anxiety, and in case of a bone marrow biopsy, discomfort. Rux does appear to improve survival, I believe, in an MF, but it may be most advantageous when used earlier, and I think that's where the RETHINK trial will be helpful, because we're going to start looking at it in patients who are lower risk, that have a high molecular risk genotype. And then mechanism-based JAK2 inhibitor combination therapies are under evaluation. It's simply too early for me to pick a winner. We could give a whole talk on the data that exists to date and the trials that are going on, but I think that we still have a lot to learn from how best to combine other agents with differing mechanisms that are rationally based, ideally, with Rux. And then Rux prior to transplant, I think at this point from the data we have from our initial MPD Arcy study and some French and German data, is that it's feasible. I'm not quite sure I believe that it's clearly advantageous. I don't know that it really results in improved outcomes at this point. And now, as many of you know, Rux is being investigated as a drug to be used in the GVH setting. So maybe there's a role in perhaps better used there. And with that, I'll say thanks for bearing with me. This is my group at Sinai. I want to thank all the investigators in the consortium, and I'll end.